This is the second part of the adrenals lecture. So we will be talking now about the adrenal cortex. So this is the part of the adrenal glands that is going to respond with association with the HPA axis. So as we can see on this picture, we are going to be dealing with not the medulla, we've already went over that, but three distinct layers, the reticularis, fasciculata, and the glomerulosa, which all have their own distinct products and also capabilities and triggers. So right now we're just going to go over the main capabilities of each of these layers, and if you would like to memorize these, this is really helpful. So the different layers that we'll be speaking about will either produce glucocorticoids, so those will involve the regulation of glucose, which is why you see that, glucocorticoids. Cortisol is the primary example of that. We have our mineralocorticoids, which will function to trigger the electrolyte ion basis of the body liquids, the body water, and aldosterone is the main hormone of action. And then finally, we have the anabolic hormones, the sex steroids. It says testosterone, but really we have a separate product made by the adrenals that we'll see called DHEAS. So there's three distinct zones. You'll definitely need to know the products of each zones and what their triggers are. And I mentioned before in multiple lectures, this is your first lecture, then you're hearing it today. Steroidogenesis is a process that involves alterations to cholesterol. So you should know that there's two types of cholesterol, our LDL and our HDL, and through a hydrolysis interaction, we have the creation then of some structures. After this initial process, we have the alteration of cholesterol into pregnenolone. And then depending on which pathway you go down, you can have a variety of different products. So the ones that we talk about most in this class, besides this pregnenolone, which is just our precursor, our first step after cholesterol, we've got our aldosterone, our cortisol, our DHEA, and that's pretty much going to be it right now. Progesterone we're going to get into more in our reproductive pathways, but these all have similar shapes. They're all highly lipophilic because they are all modified out of cholesterol. So here are your three zones and the end products. So we have our Zona Glomerulosa, beginning with cholesterol, then pregnenolone, then progesterone, and eventually going through corticosterone to end up with aldosterone. Aldosterone, if you're not familiar with it, is what we call our sodium sparing hormone. So that is going to really regulate our fluid composition, mainly to raise the blood pressure. The zona fasciculata, this is the HPA axis one. This is the only zone that is really going to have any response to CRH and ACTH. It involves the alterations of cholesterol, pregnenolone, progesterone into finally our cortisol. And the final is Zona Reticularis, cholesterol to pregnenolone, DHEA, DHEAS. And so this is this anabolic hormone that is present in both males and females so that we can have androgen mediation of function and physiology in both physiologies. Okay, so we'll start with the zona fasciculata. This is an area, most things in the abdominal cavity have a capsular structure that's a little bit more fibrous than in other areas. So there's a fibrous outer capsule. We have the zona glomerulosa, fasciculata, reticularis, and then the medulla, which we know is making catecholamines. And so these other three layers will have their distinct products. Also, as I mentioned before, when cells are steroidogenic, when they create steroids, that involves the pinocytosis, so receptor-mediated endocytosis, whereby LDL, HDL, they fill up or saturate their receptor sites, and invagination is made in the cell membrane, which means this will start to dip down, and then these two portions will snap shut to create a vesicle housing this bound cholesterol. Then that is trafficked into the cell, and we will liberate the free cholesterol. There are different enzymes which act upon it, and through this hydrolysis process, whereby the free cholesterol is modified into pregnenolone, whenever this cholesterol esterase is active in a steroidogenic cell, there's always a leftover droplet. Why that's important pathologically is you can visualize this underneath a microscope. So cells that are steroidogenic in property, they also appear foamy. So that means that there's cholesterol present in cells. And we would expect this in a steroidogenic tissue like the adrenal glands. However, when you see foamy cells in places like the aorta, that's typically a sign of stored cholesterol in atherosclerosis. So we'll see these foamy types of cells, we see alterations to cholesterol, and our rule is if it comes from the gonads, if it comes from the adrenals, then it's a steroid hormone. So the zona fasciculata makes cortisol. This is highly steroidogenic. It has receptor subtypes in truly every tissue in the body. So here's cortisol. Hey, what's up, cortisol? It has its own binding protein, a large globular protein. Transcortin is a good name for it, across and then cortisol, so it travels places bringing cortisol with it. Its full name is corticosteroid binding globulin, or CBG. When cortisol is released into the bloodstream, 90% of it is bound to its specialized CBG, and when hormones or drugs or anything are bound to proteins, they can't be active when they're on the protein. It's kind of like riding in an Uber or a taxi on your way to work. You're not working there, but you're being brought to the site of action. And then the longer you're in the Uber for, the longer you remain on the roadways. Same thing with things in the body. The more strongly they bind to proteins, the more likely they are to have a long action in the body, because they can go off, they can bind, but then if they're not broken down, they can get right back on those again. And as you know, the most prevalent globular protein in the bloodstream is albumin. So the remaining unfree, because some of everything is always circulating free or unbound, the remaining non-bound cortisol is bound to typical albumin. Cortisol's half-life, meaning the time to eliminate 50% from the body, is about 70 minutes. It is inactivated by the liver, which means that the liver would go through a typical metabolism process to deactivate it, and then eventually it would be excreted from the body. And the way that cortisol works is, first of all, it finds its receptor. And remember, for steroid receptors, they are not on the cell surface. They're inside of the cell in some region of the cytoplasm. So here is a glucocorticoid. So remember, cortisol, MOA, means mechanism of action. So the way that cortisol works is that it binds to glucocorticoid receptors. Glucocorticoid receptors are present in every single tissue in the body. Every single place in your body has a glucocorticoid receptor, which could be good, but it can also be bad. And we'll talk about that. So here we're watching the glucocorticoid, like cortisol, go into the cell because it's fat soluble. It can dissolve right through that cell membrane, which is 97% phospholipid, 3% cholesterol. So it translocates there. It just dissolves right through the membrane and it binds to its receptor, its glucocorticoid receptor. And then after it binds, there's a dimerization process. And if you're not super familiar with this word, if you just take your hands and put them together like in the prayer position, and you open them up like with your pinkies together and your thumbs go out, so kind of like you're reading an imaginary book, but that book is your hands. So you see, if your hands are lying together, they're a mirror image of one another, right? So they're side by side. So that's a simple way of describing a dimerization. So the glucocorticoid receptor binds the glucocorticoid, there's a dimerization, and then we have a translocation of that glucocorticoid receptor substance. Now it's its own unit, which then translocates into the nucleus, binds to its specific binding location on the DNA, on the gene, reads the recipe for the protein that it would like to make or not make. It can turn on protein expression or turn off protein expression. And so then we make a copy of that. We've got messenger RNA, and then through a process of translation, transcription, there's the creation of a new protein, and then an eventual change. So it's a typical steroid hormone. It's receptors inside of the cell, and then the hormone receptor complex translocates to the nucleus, binds to the DNA, reads the recipe for a protein, and then we get the making of new proteins through transcription and translation. So very typical steroid hormone action. So it's translocated, it dimerizes, binds to glucocorticoid response elements, and then we get coactivator proteins, increasing transcription and translation. When we think of cortisol, you probably think of it as the stress hormone, and that is definitely true. But when we say stress, a small amount of stress is psychological stress. Usually what we're talking about is physiologic stress. So that would be things like fasting, not meeting your caloric needs, not sleeping enough, things of that nature. So really homeostatic levels when your temperature's off, your calories are off, your sleep is off. Very basic circadian or circannual rhythms. So it is meant to keep you alive and functioning in times of physiologic stress. So if you were hiding in a cave for 3 days, cortisol's there to keep you alive. It will liberate stored glucose from anywhere it can find it. Your brain runs on glucose, so it helps maintain that. It maintains cardiovascular function during fasting, which means it can help conserve energy so that the heart doesn't run out of fuel. It protects against inflammation and immunity. So cortisol and all steroid glucocorticoids are immunosuppressive. So we do use things like prednisone, for example, or cortisone. Those are all synthetic forms of cortisol to reduce swelling and inflammation. But they're not used for long periods of time because over time they become very strongly immunosuppressive. And you'll see those drugs used in autoimmune disorders when we don't want immune cells to work. So they can have a really dampening effect on our natural immune response. Also, in times of physiologic stress, it is not good for the host to reproduce. That would have possibly deleterious effects on the embryo and or fetus. So reproductive function is stunted during times of high cortisol production. When cortisol is really, really high in cases of things like Cushing's disease, when the body senses physiologic stress and cortisol is released, again, it thinks that you're not going to eat for 3 days. It needs to keep you alive. So it starts breaking down muscle, liberating stored glucose. If, however, that glucose is not utilized, so let's say you are just really cold or really stressed at your desk all day, and now your body is liberating all this stored glucose. Instead of that being burnt up like the body would expect that it would as a fuel, it is just stored in a variety of ways. Okay. Fat maldistribution, obesity are ways that we get the storing then of that liberated glucose. So in things like Cushing's disease, you'll see that the fat is stored in abnormal places. It also increases blood glucose during any type of stress, again, to keep you alive. And where we store those things, sorry, I'm dividing my attention, which I should not do when I'm recording a lecture. So we store a lot of those things in the muscles. So what you can see when there's high levels of cortisol release or steroid usage, we get thinning of connective tissue, one of those being muscles, but also things like cartilage start to thin and bones. So I'll let you read these things because it would be silly for me to sit here and read all of them. But at the end of the day, cortisol is released to help you meet your metabolic demands of your body. So again, it is supposed to be only in times of stress. However, when there are abnormalities with the system, then Oh boy. Thank you for your patience, everybody. Man, everyone's driving me nuts. Okay, or as I like to say to my kids, driving me bonkers. So cortisol's around literally to keep you alive, to liberate your stored glucose in your muscles, in your liver, in your fat, making those free fatty acids available for energy, increasing protein synthesis. But there's also increased proteolysis, the breaking down of proteins in skeletal muscle. So again, it can be a good thing in short term. It is designed for really short bursts of high levels of homeostatic stress. However, when there's a strong high level of cortisol release, then there can be deleterious effects. So the other things that it helps you do, again, it's a stress time. So it thinks that you're dying. It thinks that you're in duress. So cortisol helps with the enhancement of catecholamine response. So if I snuck up behind you right now and was like, blah, maybe you'd be scared. Yeah, either terrified or like, what is wrong with your life? Why would you do that? And you would be scared maybe for me and my sanity, which I would really appreciate. But anyways, when you have this startle response, that initial response is going to be mediated by catecholamine release. So epinephrine, it's going to raise your heart rate, your blood pressure, make your pupils bigger, things of that nature. When those things circulate for a high amount of time, we're talking 2 to 3 days, cortisol starts to be released to help regulate everything and help keep you alive, because eventually your heart's going to run out of energy and then you would die from something called high output heart failure. So you will have cortisol working with catecholamines, increasing the cardiac output so that the heart beats in a different way, not just really fast, but it would also fill more so that you have a little bit of overfilling and then the blood pressure is maintained. It also stimulates EPO synthesis, erythropoietin, which leads to the formation of more red blood cells. That's what you see in this picture over here is a blood smear with a high amount of red blood cells. EPO is something that is taken either on purpose or it's made by your kidneys in cases of anemia. When there's low cortisol, then you can see symptoms of anemia. If there's really high cortisol, the opposite of anemia is called polycythemia, which means many cells in the blood. Anemia means without blood. Very dramatic. I love that term. Polycythemia is what you can get by taking EPO intentionally. You have way too many red blood cells. And the way they treat it is actually really fun. It's called a phlebotomy. And if you've ever visited a phlebotomist, it was to get your blood drawn. So when people have secondary polycythemia, they have to get their blood drawn periodically so that they don't wear their heart out. Okay, why is cortisol anti-inflammatory? Well, at the good level, right? So the way that we can treat inflammation by giving a cortisone, a prednisone, things like anything that ends in zone, hydrocortisone, it inhibits the enzyme that breaks down dead skin cells, or sorry, not just skin, any kind of cells. When cells break down, they now have their component parts liberated. And we know 97% of cells are phospholipids. And the enzyme that breaks down phospholipids is called PLA2, phospholipase A2. And it breaks phospholipids down into a byproduct called arachidonic acid, which can be modified by 2 different types of enzymes, which are high in different parts of the body. There's cyclooxygenase, or COX, which modifies arachidonic acid into prostaglandins, which are pro-inflammatory proteins, or the LOX pathway, lipoxygenase, is really high in the respiratory tract, and it modifies arachidonic acid into leukotrienes, which are also pro-inflammatory proteins. So when we think of things like the COX cascade, that's what NSAIDs do, like an aspirin or ibuprofen. They block cyclooxygenase, or the COX cascade. The way that drugs like Singulair work is that they block this pathway. They block lipoxygenase enzyme activity, so you don't get leukotrienes. So that would limit baseline inflammation and prevent things like asthma attacks, allergy attacks, and then the pain associated with inflammation. So when when glucocorticoids are given, it physically inhibits PLA2 so that we never get the creation of arachidonic acid. And if arachidonic acid's never created, there's no pro-inflammatory protein. So it's really, really good at blocking inflammation. The other thing that it does, if we look at this picture over here, here's a corticosteroid binding to its receptor, transcription, translation. The end result is that we have an inhibition of cytokine synthesis. And if you've learned about the inflammatory cascade, the way that we get leukocytes, like specialized white blood cells, to come to an area, that we get a complement cascade activated, the T cells come to an area, is by cell messages called cytokines. There's inflammatory cytokines that bring inflammatory cells to that area so that you can form a clot, so that you can eat up debris, things of that nature. So it blocks the resulting side effects of inflammation as well. So it's anti-inflammatory in that it blocks pro-inflammatory cytokines, it produces anti-inflammatory cytokines, and it prevents the creation of arachidonic acid. So if we were to choose like an anti-inflammatory drug, if there were no negative side effects of cortisone type medications, then we would use them all the time. They work fantastically. But over time, when you constantly give, especially a really high dose of corticosteroids, they physically depress T cell activity. And if you've taken microbiology with everybody's favorite Dr. Davy, you'll know that T helper cells, they're the ones who start the immune response. Without an immune response being started by a T helper cell, there's no resulting side effects. So glucocorticoids, they have a huge inhibitory action in preventing the production of cytokines that you need to make this cascade go on, and then also the activation of T cells. So you can actually see lymphoid and thymus tissue. The thymus is where T cells mature. That's why they call them T cells. You can see those areas atrophy because they're not really going to start making more T cells and maturing more T cells. So they're long-term immunosuppressant. So that's definitely a reason why we don't use things like cortisone drugs constantly. They are immunosuppressive. However, you will see them being used for people who we want to suppress their immune system, like in autoimmune diseases. The other things that cortisol does, as I've hopefully mentioned before, even though we have an HPG axis, HPA, we've got a thyroid one, none of those things exist on their own. They all interact together. So if there's an abnormality in one pathway, there's usually abnormalities in other ones. So when cortisol is around, it dampens reproductive behavior by decreasing HPG axis function. Again, that makes sense because when you're in a high amount of physiologic stress, it would not make sense to reproduce to the body who's trying to keep itself alive. It would have to give some of its energy to growing an embryo. It increases bone resorption. So one thing we can see is prednisone-induced osteopenia by giving extended levels of prednisone. Connective tissues in general break down with high levels of cortisone. So you see thinning of skin, thinning of connective tissues, anything with collagen in it is going to start to thin. Bones are going to start to thin. ADH secretion is going to go down, so antidiuretic hormone goes down, which means you're going to have a promotion of diuresis, so there's more water loss. There's a lot of proteolysis. Whenever any cell is broken down, it liberates its constituent parts into the extracellular fluid. Hopefully you remember that cells have a high amount of potassium inside of them. So when there's an excessive amount of muscle breakdown, you can see hypokalemia, and that K in there for kalemia should hopefully trigger your memory that K is potassium. So what happens with this is that proteolysis, that's all cleared. And so it's peed out of the body. And then the resulting shift of electrolytes causes hypokalemia. You get appetite stimulation. If you are not eating, so in the case of a fast, so if you haven't eaten for 3 days, cortisol will eventually cause the stomach to turn on. In the absence with any food in there, that can lead to ulcers in the stomach. We call them peptic ulcers from the acid called pepsin, which breaks down proteins. And then gastric acid is just, as you learn, the general term for all of the acids created by the stomach. When cortisol is really excessive and high, initially people feel really good, like, wow, life is not so bad. I've got a high level of glucose. I feel really fantastic. But when cortisol is constantly spiking, when something's labile, it means that it changes or turns over a lot. So emotional lability means you go from really happy to sad to angry. So there's a lot of emotional change. High amounts of depression can exist. Frank psychosis, when something's frank, it means that it's really easy to see. So like frank blood is bright red blood. So frank psychosis, so it could be a psychotic break, resulting insomnia because cortisol interacts with catecholamines. It's really hard to sleep when a ton of norepinephrine is pumping around in the bloodstream. Decrease REM sleep, which is when you organize your memories and also clear all the bad stuff out of your body and get some restorative rest. When cortisol is deficient, though, we can see really similar side effects. So people can be depressed. Apathy is meh. That's like when you don't care about anything, like the meh. Irritability is my favorite term in behavior. When you are irritable, it means that your personal space starts to widen. So typically you'd have like 3 feet around you as your personal intimate space. When you're irritable, it can become 5 feet, 10 feet, 2 miles. So this HPA axis, this becomes active when there's a chronic overactivation of this, this stressful, either emotional or homeostatic physiologic stress. As I've mentioned, we use cortisol synthetically all of the time. Cortisone is the synthetic, the closest synthetic form of cortisol. And you can put cortisone cream or give a cortisone shot like literally anywhere. That is because, again, remember cortisol or glucocorticoids, they have receptors in every tissue type. And then the reason why a synthetic one can work is because when you put on cortisone, cortisone is modified in a reversible reaction by this process, or by this little guy called 11-beta HSD2, and turns cortisone into cortisol. And then it can be reversed again because it's a reversible reaction. So whenever cortisol is put onto the body, if you had any, it would turn into cortisone and then vice versa. So you can rub cortisone cream literally anywhere, on your eye, on your skin, on your mouth. It doesn't matter. It will limit inflammation. They work really well. Okay, so that's that. So here's your feedback loop. This is the only area that's going to respond to that because the other products of the other layers have different triggers. The HPA axis, hypothalamic, pituitary, adrenal. Here our releasing hormone is corticotropin. So that's cortex, adrenal cortex, growth or activity releasing hormone, CRH. That binds to cells in the anterior pituitary, which releases one of the most specific hormones there is out there, adrenocorticotropin hormone, adrenal cortex growth activity hormone. ACTH binds to cells in the adrenal cortex, you get the production of cortisol. Cortisol feeds back as the negative feedback to shut off production, so we get corticotropin release inhibiting hormone created, binding to the anterior pituitary cells as antagonists and then blocking more release. All right, so cortisol regulation, CRH release is regulated by stress. Again, that is homeostatic and or emotional stress. So that could be neurogenic stress, which means created by the brain. So like when you're afraid of something, when you're anxious. It could be a systemic type of stress, your physiologic stress. So when your blood sugar's low, when you're bleeding, you might not know you're bleeding. One of the largest reasons for iron deficiency anemia in adults is GI bleeding. So you might not know that you're bleeding. You might just have a dark stool and feel kind of tired. And then a high cytokine storm, so a lot of inflammatory cytokines. As I mentioned, the circadian rhythm is also really important because that's a homeostatic set point. So you have feedback from the suprachiasmatic nucleus regarding circadian rhythm and melatonin production. Cortisol is pretty cyclical. There's one strong spike that goes up at pre-dawn, early AM. So that's before the sun comes up. So we're talking like 6, 7 in the morning, and then it starts to go down. So that's kind of why when you wake up later than that, you don't really feel that awake. The body is really meant to wake up really, really early, even though your prefrontal cortex might try to tell you that that's not a good idea, which I know I listen to mine way more often than I should. All right, well, this is an old school, terrible physiology experiment, but it's already done, so now I'm going to explain it to you. So here we're looking at the x-axis and just time, first just with seconds, and then we're in minutes. And up here we're looking at plasma concentration of first corticosterone, so that's just cortisol, and yeah, okay. Then, so we've got plasma, so just in the plasma, and then there's sampling from specifically the adrenals. So we know that cortisol is released in any type of homeostatic stressor. There's also a reason like why when you are getting surgery, even though you're not awake or aware, your body still responds to being hurt. It still knows that something in you is being modified and cut, and you have a cardiovascular respiratory response because of that. So they use paralytics so that you don't respond to that, in addition to just putting you out with a gas. So this is an animal that was, they're under for this, they're not awake. That is illegal unless it's a rat or mouse in New York State. They're not covered by that. But now you're not supposed to cause undue stress, so these animals are anesthetized. And what they did was here at minute 0, where the arrow is, they broke 2 of the leg bones of the animal. Oh, nice. So they broke their bones, and what they found is that within a couple of seconds, we see within the adrenals, the level of cortisol goes up, and then it starts to really go up a couple of minutes later. So again, this is even without the animal being awake. So same thing, now when we're looking in the plasma, so remember the immediate like startle or pain response is mediated by catecholamines. When you see cortisol pump in a really short thing like pain, a short-term stressor, it's a couple minutes later. So you see about 5 minutes after the leg bones have been broken, you see a really big spike in cortisol, and then it continues to go up because that's a big stressor. And until there is some sort of resolution to that, that's going to keep climbing. So you see this in surgery, you see this with giving sympathomimetic drugs, which means drugs that mimic the sympathetic nervous system. If you inject substances that are necrotizing, so causing tissue death underneath the skin. If you restrain an animal so it can't move, they put rats in, they're clear tubes, which we have upstairs in the animal lab for the hamsters, and they like to hang out in them, but it's also because you're not touching them. If you restrain like a rat, it would kind of be like restraining you if somebody just wrapped you up and you couldn't move in a room where people were looking at you and then they started touching you. That's kind of stressful. And then also debilitating disease, we see a huge amount of cortisol. So cortisol is definitely the stress hormone. And cortisol is directly released by ACTH binding to its receptor. Directly released. ACTH binds to its receptor. We get cyclic AMP, and then we have immediate effects. So we have activation to start making those cholesterol alterations so that we get cortisol. There is associated gene transcription, so we have more LDL, HDL receptors being produced to take the place of the ones we brought in through pinocytosis. And then long term, the cells, if they're really busy and they're making cortisol all the time, then we're going to make more of them. We're going to have more mitochondria, and we're going to have bigger cells. So they're bigger and they're going to be more active. Okay, so here are all the different things that we consider steroids. The ones that we are worried about here, we've got our cortisol, corticosterone, aldosterone, deoxycorticosterone. So these are present in really small amounts. The most prevalent is going to be your cortisol. Then we have our synthetic steroids. Obviously, you don't see them normally in the plasma, but they do have quite a bit of activity. Our synthetic cortisone really mirrors our natural endogenous cortisol. Okay, so we had our glucocorticoids from the zona fasciculata. Those are the only ones controlled by ACTH. So now we're going to go on to the zona, where are we going? Reticularis, and that is going to make DHEAS. So this is a product of the androgen type family. So adrenal androgens, DHEAS. So if you look at this across the lifespan, so in fetal tissue, or we're sampling from a pregnant female or doing amniocentesis, we see DHEA gets pretty high in the fetal levels, which everything really does at that time. It's really important with hair, and this is also the time when fetuses start to develop a lot of hair, so that kind of makes sense. And then you're born, and then there's a big break. And we don't see DHEA come around again until adrenarche. And that would be the onset of like puberty. So the older people get, the more DHEA they have. It is most strongly associated with armpit hair and pubic hair, which the onset of that is typically around 8. And then when puberty is over, it really just starts going down. It has almost no role in adults, but that doesn't mean that people don't buy it. So it is sold. You can buy a DHEA in the store, and they sell it as an androgen, like fat loss, muscle growth. But there's not a lot of data that shows that actually happens. It's more so like hairy armpits and pubic hair. So the contribution of these is pretty negligible in males because males have testes, which make testosterone. It's a much stronger androgen and has a binding capability to receptor sites that is much higher than DHEA. In women, it's 50% of circulating androgens, and it's responsible, again, most of it's body hair. So axillary hair, pubic hair, and it's also been implicated in the female sex drive. With age, it just goes down. Because you're not growing new hair in those places, there doesn't seem to be a large need for it. But again, because it is a type of androgen, it is sold, although there's no evidence it does anything but hairy pits. But for females, it might be useful for libido. That was it. So that's all that one makes. So that has nothing to do with ACTH. That's just released in a cyclical fashion, if you see here. So right before birth, when you get the hair in your head, and then when puberty starts, and then it goes down after puberty's over. So not driven by ACTH, driven by the HPG axis. And then finally, we have the Zona Glomerulosa making the mineralocorticoids. The main product here is aldosterone. This is our sodium-sparing hormone. When we don't want to add sodium to the urine and we want to keep it, because where sodium goes, water follows, we have aldosterone release. If you've learned about this, we're going to learn about this in the cardiovascular system, so I won't go into, a lot of detail here. The renin-angiotensin-aldosterone system, that is a system that is triggered when the blood pressure starts to drop to dangerous levels. There's cells in the kidneys that regulate ischemia or anoxia, which means they're not getting any oxygen, and they start to produce renin, and then we get aldosterone release. Because if you're going into shock, it means your blood pressure is really low. If you maintain your sodium, then you're also going to maintain your water in your bloodstream. So hopefully it saves you. In patho, we talk about lots of different disorders that cause weird things. And if you would like, you can read these over. And the reason I have these in here is even though physiology section of the boards is, physiology, there's randomly some questions about pathology because it all goes together. So some different diseases. Remember that I said we've got melanocyte stimulating hormone produced by the pituitary, and I said that seems out of place, but you will see that in some endocrine diseases. So you see that in Addison's disease, and Addison's disease is hypotrophy or atrophy of the adrenal gland. So it's underactive adrenal gland. So there's low cortisol, low aldosterone. So nothing is working in the adrenal glands. So both of those layers start to fail. And ACTH is high because that's the way negative feedback works. The body's like, hey guys, why don't you make some hormones? And the adrenals don't respond. So it'd be normal to see high ACTH or ACTH and then low cortisol aldosterone. And where you start to see this is with either hyperpigmentation. It generally starts in the buccal mucosa, which is the inside of the cheek, and spreads to the back, or you can have hypopigmentation. And the reason why that is, when it seems really counterintuitive or doesn't make sense, is because melanocyte stimulating hormone is associated with the pituitary. And if one thing isn't working, remember, you're going to have alterations to other things. There is a hypertrophy and overactive adrenals called Cushing's. And all those things I mentioned, when there is too much cortisol, that's what you see in Cushing's. So there's way too much ACTH, which is made by the pituitary. So the telecercica gets bigger. The pituitary itself gets bigger. There's a huge amount of cortisol that's secreted. And again, the body's not going through these periods of really high physiologic stress. So everything is broken down, so glucose is liberated and we have energy, but it's not used. So it's maldistributed in places like between the shoulder blades, lower abdomen, and then also above the clavicles. So we talk about that more in patho, but that's Cushing's. There's hyperaldosteronism. In endocrinology, the rule is whenever there is an overactive set of benign cells, you're going to get a lot of that hormone. So benign growths are really common hyperactivity causing thing. So if the aldosterone secreting cells are overactive, that's called Conn's syndrome. And because aldosterone is our sodium sparing hormone, the main symptom of this is really, really, really high blood pressure. We're talking bottom numbers like well above 100 or 150. Once you remove the adenoma, then it goes away and it's totally fine. But all of these can become overactive, and most often it's because of a benign growth. And finally, the last disorder, really quickly, is if there is an overabundance of DHEAS during development. There is a disorder called adrenal virilism. And in males, it doesn't cause a ton of abnormalities, except for things like penis length, because penis length should be something that's established later in puberty. So this 4-year-old boy is reaching an adult penis size, which usually in patho, people laugh at that and ask like, oh, what's the problem there? Well, the problem there is that not only do they have an adult male physiology and anatomy, that also means that they're going to have adult male urges. So imagine a 4-year-old boy with like a 16-year-old boy sex drive. So sometimes they do things that they can't control. They act out sexual things that they can't control. If you know anything about kids and psychology, when kids show precociousness, they have too much knowledge or they act in a mature way. It's called sexual precocity. They're precocious. That's usually a sign of sexual abuse, and you have to report that. But in this case, it's not their fault. It just means there's way too much androgen from their adrenals in addition to the one from their testes as they're developing. So in young males, they become precocious. However, when that's developmental in females, it is a much different type of physiology. So women typically should have an inactivation of androgen, especially during times of heavy development, so that we don't see secondary sex characteristics of or associated with the opposite hormone. When DHEA is around, there's not a good inactivating hormone for it. Instead, it's allowed to be oversecreted. And during times of development, what that means is that there are a lot of physical changes in females. So this is a patient with adrenal virilism, and changes in hair. So hair in males is thicker than it is in females, so the hair is more wiry and thick. There's a lack of adipose tissue in the breast areas. there's a lot of protein deposition. Her muscles are very big, but then there's also abnormal body hair placement as well. So you can see that this is taking on a much more male physique, and that's because of the androgen during development. What you can't see, and what is instead in an animation here, is an adrenal virilism. The clitoris and penis, they come from the same groups of tissues and the same germ layers. So the mons pubis and then the labia majorum. The labia majorum are essentially the female equivalent of the scrotal tissues. And then the clitoris is the same as the penis. Fun fact, there's the same amount of nerve receptors in the clitoris as there is in the penis. They came from the same group of tissues. When females with adrenal virilism, they have too much androgen during their development, what you see is that the clitoris actually lengthens to resemble a small penis. And this can be a centimeter to a couple of centimeters, and some of them are quite large. This can also happen in utero in some cases. And what you would want to do is essentially the opposite of hormone replacement therapy. You would want to give drugs to block the androgen and then also drugs to promote estrogen if that was the desired outcome. So that's just to tie it up with a little bit of overactivity of those different layers, but make sure you know the layers of the cortex and what the products are and what the stimuli are for those products. All right, thank you.